We'll start around 7, which is when the webinar is supposed to start. All right, everybody, we'll get started now. For everyone who doesn't know me, my name is Melissa Wilson. I'm a physician assistant at UPMC in Pittsburgh, Pennsylvania, in the Melanoma Center for about the past 20 years. I also am AIM at Melanoma's Ask an Expert. So when you, or if you reach out to ask a question for the Ask an Expert line, this is my face and who I am. So it's nice to see you all. Tonight, we're going to talk about immunotherapy and managing checkpoint inhibitor toxicity. So, you know, I've done talks about immunotherapy and the toxicities of immunotherapy and checkpoint inhibitors before. There are several YouTube videos and prior webinars that talk in nauseating detail about every single toxicity. I thought that it would be more helpful tonight to kind of field some of the different questions, things that people, might be wondering. One thing to keep in mind, I'm going to go through kind of my spiel in the beginning and talk a little bit about some things. I am going to leave lots of time for people to ask questions. So you put those in the question and answer bar. But you have to remember that I cannot answer specific questions about your particular case. One, because it's, a HIPAA related thing and I can't talk about it online, but also, I can't give medical advice. It's kind of outside of my legal scope of practice since you're not part of my practice. However, if you do reach out on the Ask an Expert line, I can kind of help guide you through some things and get you to the right people to help you, make some suggestions for things that you can ask your doctor. So keep that in mind when you put your questions into the bar, okay? I thought I would just start just kind of talking about some of the side effects of checkpoint inhibitor therapy, essentially because I give this spiel 50 times a day, every day that I'm at work. Immunotherapy or checkpoint inhibitor therapy, which would include Opdualag, which would include Yervoy, which would include Opdivo and Keytruda. Those types of therapies do not have direct side effects. So the drug itself does not cause a toxicity. What it does is it creates an immune response through different mechanisms that then increases the immune system response, and that immune response is what causes the toxicity. So what does that mean? So essentially, if we upregulate your immune system to work in high gear, in fifth gear, it's going to hopefully not only attack the tumor, but sometimes it attacks normal tissue that is uniquely yours. So there are a couple different ways that can happen, millions of ways actually. Basically, you can get inflammation in any aspect of your body. However, there are some common ones and then there are some not so common ones. The common things that happen are things like dermatitis, which is rash most often. Now, these rashes can sometimes turn into pretty serious rashes, like Stevens-Johnson syndrome, where you have, rash on actual mucous membranes, and it can sometimes be life-threatening. The next most common thing is actually diarrhea, which is also called colitis. This manifests typically as diarrhea. Sometimes it can be cramping, sometimes it can be bloating, sometimes it can be increase in gas or nausea if it involves the upper half of your GI tract. The next most common thing that we see is kind of a mix between pneumonitis, which is an inflammation of the lung. This manifests itself as cough, sometimes shortness of breath. Sometimes patients will just be really, really fatigued doing normal activities. That can be a really early warning sign. And then hepatitis, which is an increase in the liver functions because the immune system is attacking the liver. Now, that's something that typically oncologists see on your labs before you have symptoms, but it certainly does not mean that it can't happen, more quickly, where you do have some flu-like symptoms, not wanting to eat, things like that. And then the next most common thing are the endocrinopathies, which are when the immune system attacks the endocrine glands, which are things like the thyroid or the adrenal glands or the testicles. It can change your menstrual cycles. So there's lots of things from an endocrine or hormonal standpoint that can happen during immunotherapy. Now, again, we're not going to talk about all those things. When we look at immunotherapy, what the patients want to know, like, well, what should I look out for? So things like rashes, diarrhea, sometimes even the endocrine things, these tend to happen a little bit earlier. So these are more of like a knee-jerk reaction in the immune system where it's just causing a global inflammation. And it's not super tissue specific. So things rash, diarrhea, endocrine abnormalities, sometimes some mucositis or like an inflammation of the mouth. Like those are the types of like inflammatory things that can happen early. More tissue specific things, so liver function elevation, neuropathies, muscle inflammation, joint inflammation, and even like inflammation of the covering of the brain, which is called encephalopathy. So those types of more tissue specific things tend to happen a little bit later. That doesn't mean that they can't happen after the first cycle, but they do tend to happen a little bit later on average. So we can't, say never, but it usually is not super quick. When do side effects happen? That's the next most common question that patients ask. And really, the truth is they can happen at any time. It is really uncommon for side effects to show up within a couple days. unless it's a specific reaction that is called like a cytokine release syndrome, which is basically um, a lot of times something that happens before the patients even leave the oncology suite. Um, so most things are like weeks to months later. We do see a peak in toxicities that happen around like day 10 to 14 when patients are treated. So even like, say you're in cycle 7 and you get your treatment, you probably aren't going to have side effects within the first couple of days. Usually it takes about a week or so before we start to see things and patients call with issues. Um, there are a lot of ways that things kind of manifest themselves. So I think that if you're looking at like, well, what do I report to my oncologist or what do I report to my care team, the most important thing is something that's different. So if you're somebody who has 3 bowel movements a day and you continue to have 3 bowel movements a day and maybe they're a little bit looser, but you're not having anything else like cramping or bleeding or belching, that's probably still normal. However, if you're somebody who goes once a day or maybe once every couple days and all of a sudden you're going 3 times a day or you're having cramps when you go to the bathroom, um, or there's a change in the consistency, you certainly want to call us. Um, I will tell you, and I tell this to all of my actual physical patients, it is immunotherapy toxicity or checkpoint inhibitor toxicity is something that starts as a little teeny tiny fire, like a match. And if you ignore it, it'll light your whole life on fire. So it's much easier to treat an adverse event when it's a teeny tiny problem than when it's a big, gigantic, blazing fire. That doesn't mean that it cannot be corrected. It certainly can. We have lots of drugs now that we didn't have 15, 20 years ago. That make that a little easier for those, high impact toxicities. But it is a much easier thing to put out if it's reported early. So any kind of change that you have is something that you should call your oncologist about. If it's not your normal, you should call. Worst case scenario, they tell you, hey, okay, that's not something I'm super worried about right now, but keep an eye on it. If it worsens, you call us back. Then the reassurance is something that is nice. You can always reach out to me and I will tell you those things. So if you feel like you don't want to bother your oncology team, it is absolutely appropriate to reach out to the Ask an Expert line. And I'm happy to tell you if it is something that I think that you should report immediately or, if we can talk through the problem. What symptoms are considered urgent? So any kind of bleeding from any place in your body. So if you throw up blood, cough up blood, have blood in your stools, blood in your urine, any kind of blood coming out of any place is something that you should urgently call about. If you throw up more than a few times and have no sick contacts, you should call us. If you're having any kind of what would be severe abdominal pain, so anything that you would scale on a scale of 1 to 10 greater than 5, you should give someone a call about. If your bowel movements double, you should call us. So if you're having 1 bowel movement a day and now you're having 3 bowel movements a day, you should give us a call about that. Any type of symptom or sign that wasn't there one day and then is there the next day, you should always call. Again, there is no harm in letting someone know that something is going on because then we can monitor it. And that's one of the things that I try to stress to patients more than anything else is that if we don't know, we can't help. So there is no such thing as an under, too many, I don't want to say too many calls because that maybe isn't the right thing, but there's no such thing as your oncology team not wanting to hear that something's different in the course of your immunotherapy treatment. So it's definitely better to call too much. What can you do at home? So there are some people that will say, well, I don't want to bother my doctor with a rash, or I don't want to bother my doctor if I have just 1 extra bowel movement a day. So there are some things that you can do for like mild side effects. So let's say that you wake up, it's a Tuesday morning, and you have this new rash that is a little bit itchy. It's a, couple inches big, or it's underneath your armpits, and you're a little bit worried about it, but it's not causing you too much distress. Some of the things that you can do first, and this is something that we would tell our patients to do if they woke up and they had a new rash, we would say, okay, you're going to start an antihistamine every day, because what we have learned is that sometimes whenever the immune system is upregulated, it also increases levels of histamine, because that's an inflammatory chemical that creates sort of creates that sort of itchiness and sneezing, and creates an increase in, the cytokine or the inflammatory part of your immune system. So that increase in histamine can be blocked with antihistamines. So we will use Zyrtec a lot of times, or Claritin for rashes. We will tell patients to start that right away, and you have to take it every day. It's not something that you can kind of periodically take. At the first sign of rash, we have people start an antihistamine. You want to keep your skin nice and moisturized, because it's dry, and when things are dry, they get more itchy. So you definitely don't want to walk around allowing your skin to be dry, because that's going to make your symptoms worse. You can certainly try over-the-counter topical steroids like cortisone 10 and things that you could buy in the pharmacy. A lot of times the strength of those isn't quite enough for an immunotherapy-related toxicity. However, it's a good start, especially if you can't get in to see someone, like maybe it's Sunday, or late evening, and you may not get to see them until the next day. So those are things that you can try. Another thing that is kind of may sound silly, but wet a paper towel with cold water and lay it on your skin, or put an ice pack on something if it's extraordinarily itchy. Cooling down your skin like that can really help that sort of itchy, like I want to scratch my skin right off of my body sensation. Right now in Pittsburgh, it's like 5 degrees, so you could just go outside for a little bit. But that cold is really good for rashes, especially for calming the inflammation down, making it less itchy. So don't take hot showers, take, warm showers. Try to, kind of take care of your skin from a symptomatic standpoint. For the most part, those people are probably going to need some type of topical steroid, but that's kind of what you can do in the meantime. As far as diarrhea is concerned, we do not discourage our patients from taking Imodium. So we always tell people, have some Imodium in your house. If you have diarrhea, sometimes diarrhea happens for normal reasons. So if you have a bout of diarrhea and that's not normal for you, take an Imodium. I will tell you that, and checkpoint inhibitor diarrhea will scoff at Imodium. It's not going to really do anything to prevent it from continuing to happen. So that's kind of one of our stop checks at first. Like if someone calls in and says, I had a couple bouts of diarrhea yesterday, we'll have them try some Imodium first. You can always do what's called the brat diet, which is just a bland diet: bananas, apples, toast, rice. Those are all things that generally tend to be pretty calm on the stomach. So you can try eating that for a little bit. But those are, just like the normal everyday things. Those still can help, especially if they're not from the checkpoint inhibitor therapy. If those things don't work, you need to make sure you call us. There are lots of over-the-counter medications that are okay to take, but I always try to encourage patients, whether it's on the Ask an Expert line or in my practice, that they really should just call us. Things like Benadryl, Zyrtec, Claritin, Imodium, Pepto-Bismol, all of those things are safe, but if you start taking them, we want to know, because that means that we need to monitor you a little closer to make sure that those things don't progress. Let's see. The other thing that patients always want to know in our initial talks about checkpoint inhibitor therapy is, you know, am I guaranteed to get these side effects? The answer is no. There are about a quarter of patients that will get toxicity from the checkpoint inhibitors. Combination therapy like Ipi/Nivo will sometimes cause a more severe reaction, meaning that if you have diarrhea, it might not creep along at 1 to 2 bowel movements a day. It might progress pretty quickly, 3 and 4 bowel movements a day, sometimes cramping. So like I always tell people that the combination therapy of ipi/nivo is a little bit more severe toxicity. It doesn't mean that there are different ones or that new things happen. It just, we need to act on those things a little bit more quickly than we would sometimes the single agents. Now, does that mean that single agent ipi or single agent nivolumab or single agent pembrolizumab can't cause severe toxicity? Absolutely not. They absolutely can. So it's not necessarily true that you know the combination is the only one that causes severe toxicity. So the take-home message is, will every person get side effects? No, they won't. The vast majority of people actually probably won't get severe side effects. But when they do, and if they do, we certainly have many, many ways to treat them. And the most important thing is communicating with your care team. So what if you don't get adverse events? Because that's the other question that patients ask, like, well, if I don't get side effects, does that mean the treatment's not working? No, because in the clinical trials and in all of the data that we have over the years, sometimes patients get fantastic results and have absolutely no toxicity at all. So while there are some things that if we see, say, for example, colitis, or we see, say, for example, dermatitis, historically, those toxicities have correlated in some of the retrospective analysis that has been done with a positive response. But that doesn't mean that if you don't have those things that you're not going to respond, because it's actually, in reality, more common to not get side effects than it is to get side effects. When do we need to stop treatment for toxicity? The answer is basically once it becomes grade 3 in most cases. So there are some instances where we stop it at what's called grade 2. These are things that are decided, and we use this special tool called the CTCAE. So it's a standardized toxicity manual that gets revised all the time. And it very literally like lays out, okay, if you have liver functions that are this many times the upper limit of normal, it's grade 2. If you have skin rashes that involve this much of your skin, it's grade 3. So you follow that CTCA guideline to grade a toxicity. Most of the time, grade 1 things, we're using symptomatic care, lotions, Imodium, antihistamines, warm shower, like those kinds of things are typically done for grade 1 side effects. Grade 2 toxicities tend to be a little more severe, or they're very persistent. So, we're throwing lotion at your rash, we're putting antihistamines on it, it's not doing anything. So then we start to think about initiating steroids. Sometimes at grade 2, we may delay your treatment while we treat whatever toxicity happens to be happening. But a lot of the toxicities, we don't have to stop at grade 2. Now, as soon as it becomes grade 3, so the severity meets the criterion to be called grade 3, that is a discontinuation of treatment. Now, again, does that mean that your treatment's going to stop working? No. What we do at that point is we stop treatment. A lot of times these patients will be on steroids, on a pretty long, like 4 to 6 week taper of steroids. And those steroids don't negate the treatment. So they don't turn off the immune response that we have created. And a lot of times when we see those toxicities, now not always, but a lot of times the general trend is if we see those toxicities, we actually see a response too. And so everyone is very worried about like, well, if I take steroids and that's an immunosuppressive, that's going to turn off the immune response. We actually know that not to be true. They looked at this data over time, and we know that that's not what happens. So it's something that you still will have a robust immune response. We're just kind of turning the dial from hyperactive, out of control, back to, hey, we're making an immune response to attack your cancer. But we're not going to attack all the other things too. So we're just turning it down. We're not turning it off, if that makes sense. So that's extremely important. Do the steroids always work? A lot of the time they do. A lot of the times, as long as you're robust with the steroids, meaning that you use the recommended 1 milligram per kilogram, and you taper it very slowly over 4 to 6 weeks. It stinks and steroids are terrible and toxicities, are hard. But if you do it correctly and you do it once, a lot of times those toxicities will be managed with just prednisone. What happens if they're not? It's okay. We have lots and lots of things now. We're using IL-6 inhibitors, like one specific drug is called tocilizumab. We've used that in a bunch of different toxicities now. We can use tumor necrosis factor agonists. Some of those drugs that you might hear these words are like Remicade or infliximab. We use vedolizumab, or Entyvio, it's called. So there's lots of different additional agents. We use CellCept a lot. So there are a lot of other immunosuppressives that are a little bit more robust and a little stronger than prednisone because they last a little bit longer and have a more long-term like half-life. But we have lots of those things that we didn't have before. So if your toxicity doesn't respond to prednisone, it doesn't mean that it may not respond to something else. And so that's kind of the spiel that I give my patients. The other thing that is really important when you're talking about immunotherapy or checkpoint inhibitor toxicity is kind of addressing the people that are going to take care of the patient. So, you know, encouraging caregivers to be mindful of the side effects and bring them up to the patient if they don't seem to be noticing that, like, hey, when you cross the room, you seem kind of short of breath. Maybe you should call your doctor. Or I've noticed that, you went to the bathroom a bunch of times. Like, what do we do? So, I just want to always encourage caregivers to have understanding because there are lots of things that are not ideal when patients are going through treatment. But also you just want to watch for changes in behavior, changes in, eating habits, changing bowel movements, things that maybe someone might not notice. Like we had a patient that went to the gym every single day prior to starting checkpoint inhibitor therapy. I almost said which one. I'm not going to do that. But anyway, they went to the gym all the time, and their girlfriend was like, "Hey, I noticed that um, patient X, stopped going to the gym every day. He's only going maybe once a week, maybe, and he's sitting on the couch all the time." So we did an endocrine workup on him, and turns out he was not only severely hypothyroid, but he also had adrenal insufficiency. So like changes in routine like that, sometimes, people can slough off as, oh, I'm going through treatment. I don't feel like doing stuff. But they could actually be a significant problem. So, you want to just like watch for changes in what their normal is and report that or encourage them to report it. And just be there for them. If they want to talk, if they don't want to talk, just support them in whatever they need and ask them what they need because they might be somebody who just wants to be left alone and that's okay. You can help from afar. Okay, so that's my spiel. Let's look at some of these questions. So Jennifer wants to know, what about eczema? So we don't typically see eczema worsen unless it is in an area that is inflamed with the immunotherapy already. We use all the same drugs actually that they use in eczema, we will use sometimes to treat refractory rashes. Like we even put a patient on Skyrizi a few weeks ago. So there's lots of like you treat eczema actually the same way because eczema is also an inflammatory reaction. So keeping things very moisturized, making sure that you utilize topical steroids when needed. There are some immunomodulating treatments now, specifically for skin disorders. I can answer those offline. But those are things that you can do for severe eczema also, even if it's not related to immunotherapy. Um, Jessica from Facebook's wants to know, are there any lotions that are recommended over others for moisturizing? You really want something that is a good emollient. I know that that might, I don't know how to describe it. Like you don't want to put something, like if you squirt your lotion in your hand and it's watery and runs around, it's not going to really stay on and absorb into your skin. So you want something that's like kind of thick when you're rubbing it in. So there are brands that we recommend to our patients. You want to like try to avoid things that are like heavily perfumed, because that can sometimes irritate the skin even more. Um, so like I don't want to say like unscented. I mean, we've told patients sometimes to put Vaseline on their skin. So like truly like anything that like is a very thick emollient, does a really good job because it almost kind of creates a barrier on the skin to kind of keep things moisturized. If you're like my husband and you absolutely despise the feel of lotion on your skin, um, and I'll probably get in trouble for saying this, but there's a lotion called Utterly Smooth and it's recommended by surgeons. But it soaks into your skin super fast. It's actually really thick. But as soon as you rub it in, you can't feel it anymore. And I know like CeraVe, there's all kinds of really good emollients out there. But you really want something that's not runny. And definitely not something that is heavily perfumed because that'll irritate your skin even worse, especially if you've been scratching and it's open. It'll feel terrible. Jacqueline. So it says, how do you deal with the GI problems caused by ongoing prednisone use because of adrenal insufficiency caused by toxicity? Jacqueline, if you want to reach out to me, I can answer this offline. Okay. Donna, this is actually a really good question, Donna. It says, if you suffered from immunotherapy-induced colitis from Ipi-Nivo, what is the likelihood that you would suffer it again from just Nivo? So, if you were active, okay, if you had Ipi-Nivo, I will tell you that a lot of times the colitis is caused by the Ipi. Um, so we will re-challenge almost, I would say, 99% of our patients with Nivo once they've recovered from their diarrhea from Ipi-Nivo. And this is true even if, like, let's say you got the 4 doses of Ipi-Nivo and then you started maintenance nivolumab and you're like 3 or 4 treatments in to the maintenance of just Nevo and you get really bad colitis, that's still probably from the IPI. Ipilimumab has an extraordinarily long half-life, and so we almost always will assume it's from the IPI part, and we will re-challenge with Nevo. Now, if you had colitis from nivolumab, like single agent nivolumab, and you had colitis, um, we probably wouldn't challenge right away. I have seen oncologists switch to a different, like switch from, say, nivolumab to pembrolizumab and have patients that didn't have the same issue. So there are special cases like that, but that's something that you would definitely want to talk to your care team about. But for sure, um, Nevo after Ipi-Nivo is actually really a common thing to do. Jennifer asked, what type of steroid refractory toxicity do you use tocilizumab for? We have given it for arthritis. We've given it for myositis, so muscle inflammation. We've given it for, it was first used and most commonly used for pneumonitis, so inflammation of the lung. We've used it for steroid refractory rash. We have used it for steroid refractory neuropathy. So it's getting a lot more use in different types of toxicity, but the main ones are pretty much um, arthritis, myositis, arthritis, muscle pain, pneumonitis for sure, and dermatitis. Those are what you commonly see that for. Um, Carmen wants to know, what if you develop symptoms after hours on weekends? A lot of the places that are giving immunotherapy actually have call lines. I know the University of Pittsburgh does. We have a call line that's manned um, by a fellow and an oncology nurse. You can always reach out to me. Um, by the best way to reach me quickly, especially like and on the weekend and at night is actually by email, believe it or not. So there's a form that you can fill out on the Ask an Expert line, and it shoots to my phone. The call line, I also get those calls too, but sometimes I won't get those until the next day because they're set to go to the voicemail. Um, so, if you get colitis and it's Saturday night, you should try to call your oncology team because there's a chance that somebody is on call. If they aren't, you can certainly reach out to me and we can try to talk you through the management. And I'll let you know if you need to go to the ER for sure. Um, Heather. So Heather Ross, I want you to reach out to me offline. So you can go to the Ask an Expert page and I will absolutely answer your question for you, but I have to do it offline. I think that's it. So let me look and make sure there's no other comments on Facebook. Let's see. Mm-mm. Do side effects get worse over time? So this is gonna be the last question I'm gonna answer, and then we gotta go because we're already 2 minutes past. Um, so Jessica, side effects don't necessarily get worse over time unless they're not addressed. So if you have a true toxicity from checkpoint inhibitor and you just ignore it. So like, let's say you get a rash from that and you completely ignore it. Will it get worse over time? Yes. So it's sort of it's like the snowball effect. A lot of time this inflammation kind of feeds more inflammation. So a perfect example is the colitis. So if you might wake up and you have 2 bowel movements, and then a couple of days later, maybe the next day you have 4 bowel movements, and then you might have 6 bowel movements. And so the inflammation starts as a little tiny snowball and can end up like a big giant avalanche. So you need to definitely break that inflammatory cascade because it's just going to keep like potentiating itself. Um, but it's not dose dependent. A lot of patients will ask that. So like if you have 2 treatments or you have 6 treatments, your toxicity at 6 treatments isn't going to be any worse than it would have been if you got it at cycle 2. It has nothing to do with that. So it's not the more treatments that you have, the worse toxicity you're going to have. It's just the more treatments you have, the more exposure to the drug you have, which means that your immune system at any point in time can really be triggered, to go haywire. All right. I really hope that helped. I hope I'm absolutely willing to answer any and all questions. Um, outside of this. We can do another webinar like this and I can just answer questions if you want. So please feel free to reach out. I hope that you guys got a little bit of something helpful from this webinar. It's always my pleasure to do these little educations, and I hope we can do some more. I hope you have a wonderful night and stay warm. We'll talk to you soon.